morning and welcome to Morningside Ministries. Our presentation is Shingles, what every nurse needs to know, probably what everybody needs to know. I welcome you to our program today, and mmlearn.org is our site that you can go to watch many programs, and we're delighted that you've joined us. Shingles has another name. It's called herpes zosters. And herpes zosters is a form of the varicella zoster virus infection. Varicella zoster is the same virus that causes chickenpox in childhood. And there are adults who do get chickenpox, so I will say that here. But mostly you need to know that it is the same type of the herpes virus. It establishes a latent infection in the sensory ganglion at the base of the brain and the spinal column. Now, many people ask me, is this herpes the same herpes that you get when you have a venereal type zoster? And that is not. That is a herpes simplex. We'll talk about that in a little bit, but I just want to make sure that you understand that the herpes virus that we're talking about is of the varicella zoster type, the form that causes childhood chickenpox. So I like to start out with a video because I think this really tells us a lot about what people experience when they go through an episode of shingles. There's numerous individuals that share their experience, so I'm going to let you watch this for a minute, and then we'll pick up from there.
I had never heard of shingles before.
I knew it was shingles, but I didn't want to think it was shingles.
Mostly it felt bad. It hurt. Nobody I've ever encountered expects to get it, and they didn't realize they were vulnerable.
Welcome to Spotlight on Shingles. You know, making informed decisions about your health starts with having the facts. And here are a few important facts about shingles. Up to half of the estimated 1 million shingles cases in the U.S. each year occur in people 60 and older. 1 out of 2 people who live to age 85 will have had shingles. We are here to be a source of information on shingles and its potential complications. At Spotlight on Shingles, we have the opportunity to hear the stories of people who have experienced shingles firsthand. Now we'd like to share some of those stories with you.
I was working on renovating my house and using a paint remover that was quite caustic. So when I first started experiencing a burning pain up in the upper right quadrant of my stomach, it felt like I had burned myself. It didn't surprise me because I was working with this material.
As I was driving back from Massachusetts, I noticed the beginning of a tingling, I would describe it as a painful itch throughout my back. About a day later, it erupted into a rash, and it was several days after that I actually finally decided to go to the doctor.
I went to the doctor and showed him the 2 little blisters that I had on my side, and I explained to him that the area around that really did hurt. It hurt enough that I couldn't put clothing on. I couldn't take a shower. I couldn't be out in the air sometimes. Even the breeze hurt.
Well, the doctor diagnosed it immediately as shingles. He described it as a teardrop on a rose petal because there was a little bit of a blister on the red rash. And when he mentioned shingles, I was really taken aback, because I hadn't heard about shingles, didn't know what it was.
I really didn't know anything about shingles whatsoever, and I certainly didn't know that it was likely to hit me.
Jill and Dave aren't alone. In fact, a national survey of more than 1,000 older people found that many older adults who reported not having had shingles were unaware of their risk for the disease. So what puts you at risk? Well, take a look at these. Look familiar? If you've had chickenpox, and more than 90% of adults in America have, you're at risk for shingles. Shingles is caused by the same virus that caused chickenpox. When someone has chickenpox, the virus can live but remain inactive in certain nerve roots within your body for many years. If it becomes active again, usually later in life, it can cause shingles. Risk for shingles increases as one gets older. But what does shingles feel like? Well, as you're about to hear, shingles symptoms and their severity can vary from person to person.
The first week with the shingles was very, very unpleasant and uncomfortable. And the second week was still uncomfortable, but less intense. And by the third and fourth weeks, it was there, but wasn't really on my mind. I just went on with the normal activities of my daily life, and that helped keep my mind off of what was happening.
It lasted about 6 weeks of real discomfort, and then another maybe 6 weeks of minor discomfort before it was fully gone.
It not only hurts to have on clothes, it hurts to take a shower. Air hurts.
On occasion, the pain becomes very intense. It's a sharp pain that just hits you to the point where it makes your whole body jump.
You may not be able to see the first signs of shingles, but you often might feel them. These may include itching, tingling, or burning. A few days later, a rash of fluid-filled blisters appears, usually on one side of the body or face. The shingles rash can be painful, and the blisters might take 2 to 4 weeks to heal. For most people, pain from shingles rash lessens as it heals. But for some people, shingles can cause long-term nerve pain that can last for months or even years. This is called postherpetic neuralgia, or PHN. The older you get, the more you're at risk for long-term nerve pain. Other serious problems that may result from shingles include skin infection, muscle weakness, scarring, and decrease or loss of vision or hearing. So if you've had chickenpox, what else do you need to know?
That this could happen to you, and please try to be alert to it, and if you get any symptoms, to go to your doctor right away.
I knew right away that it was the shingles, and I called my internist, and even though it was a Saturday, he agreed to come into his office, and he saw me and confirmed that it was the shingles, and he gave me some medication, which I started immediately.
I'm hoping that people will learn more about shingles. If they have some of the symptoms of shingles, that they will go to the doctor as soon as possible.
As these folks have learned, it's important to seek medical attention immediately if you think you may have shingles. Your doctor can prescribe medications which should be started as soon as possible.
I've talked about shingles with a lot of people, primarily because it was such a big part of my life for a couple of months.
I had never heard of shingles before, but since having it, I have talked to a lot of people, and they say, oh, I've had it before, and then they say, I know so-and-so has it right now.
I think it's important to talk about your shingles experience because since others of my age are susceptible to it, and if they haven't had it, they should be aware of it.
So this is a reality. It's all of us out there. It's anybody that has had chickenpox can have it.
If you're age 60 or older, you should talk to your doctor about your risk for shingles. It's also important to share information with older friends and family members. Visit www.spotlightонshingles.com for more information. You can also order a free copy of the Spotlight on Shingles, Know What You Can Do disease education brochure by calling toll-free 1-877-RISK-4-SHINGLES.
The reason that I feel that this video is important is for two purposes. Number one, I think it's very informative. But the other reason is because every one of these individuals who spoke today could speak for themselves and tell you about the pain they experienced, tell you about the discomfort, what was the onset, and we'll talk a lot more about that. But who I want to address today are those residents who are unable to tell us about this, those people who are cognitively impaired and who acquire shingles. I think that we have to be the eyes and the ears. We have to be able to train all of our staff, and this is the role of nurses in long-term care, to work with our staff to help people who are at risk for shingles and to prevent the postherpetic neuralgia, or at least to reduce that. It was very clear that there's a lifetime risk that ranges from 10 to 30% for people to have shingles. And it increases in the 5th decade of our life is when we begin to see a surge of people who get shingles. I do want to say that although we know it peaks in the 7th and 8th decade, 50% of the people who are 85 or older will have suffered from shingles or who will get it. But I want you also to understand that younger people can get shingles as well. I tell the story, my daughter was in medical school and they were doing an examination, and this young man, they asked him if they could look at his back, and they were looking at the spine, and the doctor diagnosed this young person who was in his early 20s with shingles, and he had very little effect from it. He wasn't in pain, he wasn't having any discomfort, but he indeed had shingles. So it presents differently, and it can present at any age. Most people who present with this pain describe it as shock-like or a continuous burning sensation at the onset. And within 2 to 3 days after this, the skin lesions develop at the area of the involved nerve segment. So that's sort of the onset of what this disease looks like. There are special forms of shingles and other forms that are like the trigeminal zoster, Ramsay-Hunt syndrome, and a sacral zoster that can cause some paresis. I think we're very uninformed, to be honest with you, and I think if we haven't studied this in a while, and I wanted to just review with you all very quickly the Ramsay-Hunt syndrome that comes with shingles. And Ramsay-Hunt is a disorder of the brain and nervous system. It's a neurologic disorder that occurs, and it is when the virus, the varicella zoster, infects certain nerves of the head. I think we need to be very aware of this as nurses, because the symptoms of this are it can cause a hearing loss on one side, a painful rash actually on the eardrum, tongue, or the roof of the mouth and the palate, on the same side as a facial weakness that forms. Sometimes people, when they have a weakness on one side of the face, immediately are thinking of stroke, and we need to always remember there's other things that we need to be attentive to. There can be sensations of things spinning around. That's because of the ear involvement, the inner ear, a vertigo that appears, and a weakness of the face, difficulty closing one eye, and a smile that may look crooked. So for those of you who are very attentive to looking for stroke, we want to make sure that we're always aware of some other things that could be happening, and even training our employees about some of this. I think that's especially important. One other case that I want to talk to you about that comes with this form of shingles, this varicella zoster, is something they call a prognostic indicator, and it's called the Hutchinson sign. And I have a photo of this, but it absolutely so took away my staff looking at it that I decided not to use the photo today. But if you'd like a copy of it, you can just email me at info@mmlearn, and I'll be delighted to send it to you. But what a Hutchinson sign is, it's the appearance of a typical lesion of herpes zoster at the tip or side of the nose or the root of the nose. And this is an area of the skin that's innervated, and what happens is this usually involves the eye, and you'll get a real periorbital edema and true inflammation, and then you can actually begin to see the blisters on that side. But I want you to know it's not always a positive sign, but many times it is. So when somebody begins to talk about the tip of the nose, complaining of redness, blistering on the nose, anything with the end of the nose, it is something, and we want to be very careful because of the eye involvement that could be there with the Hutchinson sign. I'll be glad to send you a photo if you'd like one. There are so many complications from shingles, and I think it's just really important that you understand these so that we begin to think about how can we prevent this, and if it does occur, how can we minimize the complications. There's centralized zoster. Usually you heard that it's midline, only one side of the body. That's not 100% of the cases, because you can have a totally generalized zoster. The postherpetic neuralgia is one of the hardest things we have to deal with, and is one of the things we're most concerned with, next to, of course, these serious conditions called encephalitis, delayed hemiparesis, and then acute retinal necrosis. We do not want somebody to lose their vision because we did not act in a timely manner. Whenever I teach these classes to nurses, I'm teaching you to train the frontline caregivers. Those CNAs, nursing assistants, medication aides that are spending so much time with the residents, they are your eyes and ears, and you need to train them what to bring to you, what to report as a significant change of condition. And most importantly, when they bring it to you, to listen and to go look and see for yourself and perform the assessment. What do these skin lesions look like? Well, the skin lesions begin as a bright red skin plaque. The gentleman described this as kind of a red rose that had a little raindrop on it, or a little drop of water. It actually is tightly grouped papules that develop within several hours to a few days. So many people have what they call prodromal syndromes before they ever see the rash. And these are the symptoms that they have prior to the eruption of the rash or the lesions. These lesions evolve into vesicles, and then they get into little flaccid papules. And the eruptions peak in 4 to 5 days, and then they usually heal over a 2 to 3 week period, and they will crust over. It's so important to understand what provokes herpes zoster and what contributes to shingles development. We know some of these for sure. We don't know everything. Some seem not to fit this pattern, but these tend to be very common. One is stress, increase in high development of stress, probably why the young man in medical school had this. Immunosuppression. Immunosuppression, we especially see this if people are on chemotherapy, high among people with AIDS, and other people who have had transplantation that are on immunosuppressive drugs. Physical trauma to the infected sensory ganglia can also provoke factors and can provoke this disease. Radiation therapy, and believe it or not, spinal manipulation, which we think about as chiropractic medicine, has had some, and we sure don't tell people not to see a chiropractor, but we do know that spinal manipulation can innervate this and possibly bring on a case of the herpes zoster. What does the therapy look like for this? Well, the initial treatment is antiviral medications, and these are like your acyclovirs and other cyclovirs that are used to reduce the pain and the duration of the herpes zoster or shingles. What I do want to tell you about antiviral medication and why this is so important for all of us to understand this is most doctors will not utilize this after 72 hours of the onset of the disease. So, prompt recognition of shingles is imperative. And these people told you there was a burning sensation, sometimes pain in the shower, sharp stabbing-like pain, shooting pain, burning. So if a resident who doesn't have any other indications of this talks about having any of these symptoms to a CNA, to you, to their physician, to their family member, and it's brought to your attention, we don't want to wait to get these folks to a physician or to have the physician come in to see these residents, because we know that if we can start the antiviral medication within 72 hours, we have an opportunity to reduce the duration of the disease as well as to reduce the implications or the chance of having a postherpetic neuralgia. These postherpetic neuralgias can be totally incapacitating, and we'll talk about that in a minute, but I want you to know the power that we have to make a difference in these people's lives by acting immediately. Over-the-counter pain medications can be used to reduce the pain, and these are things like acetaminophen, aspirin, ibuprofen, and they help to reduce the pain during the attack. I want you to be very careful because we've had a lot of literature, a lot of information put out to us about acetaminophen, and that is because of the effect that it has on the liver. So we sure don't want to over-medicate anybody with this or allow them to self-medicate with acetaminophen, and sometimes the pain is so great they may do that. So we want to be very, very careful with that. Corticosteroids are steroids in combination with antiviral medication they use to help reduce the pain and the duration of the disease as well. There are some contraindications to using steroidal therapy. That's up to a physician to make that assessment. And topical antibiotics, and that's to stop the infection of blisters. And we're going to talk about that in a minute as well, because infection is something that we as nurses and as the healthcare professionals in these long-term care environments have an opportunity to assist to allow these folks not to become infected, and we can help with that. It is so important that we talk about postherpetic neuralgia, and I'm going to start with the characteristics of it. Postherpetic neuralgia, the pain that persists after the disease has resolved. And what we're going to talk about is the blisters are gone and the person still has pain. They will usually diagnose a postherpetic neuralgia at 90 days or 3 months after the original eruption. However, many people begin to experience this much sooner, and doctors will begin treatment sooner. But you have to know that this persistent pain in the affected nerve segment after healing can be just disabling to people. Older age is the most significant factor for postherpetic neuralgia. So we know that if it peaks in the 6th and 7th decade due to the lower ability for the nerve regeneration, we have to do anything we can to help minimize postherpetic neuralgia. One of the things is getting the antiviral medications, and then we're going to talk about also an immunization. Postherpetic neuralgia, as we said, is considered when the pain continues more than 3 months and after resolution of the eruption, but that doesn't mean somebody shouldn't seek help before 3 months or that a doctor shouldn't be consulted regarding the pain management for these folks. We know in long-term care under the federal tags and all of our regulations and what we're trying to do for quality of life for our residents, one of the greatest things that immobilizes people, keeps them isolated, changes their quality of life is pain. And so we have to pay particular attention to this. Anybody who has a developed case of shingles should have great care planning done, and the employees should be made very well aware of what we can do to minimize this for residents. Postherpetic neuralgia, what is the ongoing treatment for this? Well, the focus is mainly to reduce the pain. And when I first did the study and brought up this program, antidepressants were not considered, they were considered off-label use, and now the FDA has approved antidepressants for the treatment of postherpetic neuralgia. There's some discussion whether the antidepressants are actually working to minimize the pain or whether the antidepressants are because the person is so depressed because they are in such pain and it causes mood disorders. But I think there's great evidence that it does work with postherpetic neuralgia. Topical anesthetics are used, things like lidocaine. Anticonvulsants are also used for postherpetic neuralgic pain. Opioids are used, and topical creams that contain capsaicin. There's some new studies going on with actually oral capsaicin, and those have not been approved yet, to my knowledge, for the treatment of postherpetic neuralgia, but there are some great studies that are happening. As a nurse, what do we need to think about? What do we need to tell the CNAs? What do we need to tell the med aides? Dietary. Anybody that works with the resident, what does the interdisciplinary team need to know? The minute we begin to implement any of these treatments for pain, we have to recognize what are the risks and what are the side effects. And when we look at opioids and these antidepressants, we need to think about increasing hydration because of constipation that can occur from these. There's so many side effects to any drug that we implement with a resident that we want to make sure that all of our staff knows what to be looking for, and we want to measure that what we're doing is actually making a difference in reducing the pain level for this resident. So when we do post-pain assessments or post the medication administration and then we assess the pain, we should be very careful to make sure that what we're giving these residents is helping them. It means nothing for these people to be in all this pain, even though we implement this, if it isn't the right medication for them. Pain is a topic all unto itself, a program that we do, but I just feel this is so important with shingles to make sure that we discuss. So let me take a question for a second here, or a comment. Can you have shingles without the blisters? And actually, you'll usually see the blisters, but there are some cases that, yes, that has happened. And then it says, once you've had an outbreak, are you susceptible to more outbreaks, or do they become more frequent? That's a great question, and I'm going to answer this and tell you in two parts, and we'll get to this in a minute as well. But usually, once you've had shingles, it's not usual for you to get it again. However, there are many cases that are cited that folks do get it again, and I have seen people who have had shingles more than once. So that question is yes and no. And the likelihood is low, but can it happen? Absolutely. And as far as the frequency goes, I don't have any information that once that you've had it more than once, is it going to be more frequent? I don't have information about that. But we are going to talk about a vaccine in a few minutes if you've already had shingles. So that's a great question, and thank you for asking it. So we move on to exactly that point, and it is about the vaccine. The vaccine is a live zoster vaccine, and it was approved in 2006 by the FDA. And it's approved for those people who are 60 years or older. They don't give it to anybody less than 60 years of age. And it is a single dose, and it's given in a subcutaneous injection. It's given in the deltoid muscle usually. It's not approved when you've had the herpes zoster infection for postherpetic neuralgia. However, they do give the vaccine even if somebody has had the herpes zoster. Not all the time. These decisions are made by your physician, and I'm surely not recommending what you do, but there are people who do give the vaccine even if you've had shingles. Now, the question here is, would you give this vaccine to someone like me who's never had chickenpox? And the answer is no. It's a live vaccine. They would not give me the herpes zoster vaccine. I've never had chickenpox. So I am not susceptible. I will not develop herpes zoster or shingles. What I would get is chickenpox. Can I get chickenpox from somebody who has shingles? We're going to talk about that. Hold that question for a minute. This is contraindicated in individuals with severe reaction, and they actually say any reaction to gelatin or neomycin. Those are components in the vaccine. So if you're allergic to gelatin, you're allergic to neomycin, and there's a few other things that they'll question you about before giving the vaccine, you would not be eligible for the vaccination. Sort of the same thing if you get a flu shot. If you're allergic to eggs, you're probably not going to be able to get the flu shot. And there's some other preservatives that are in the vaccine for flu. The same thing for this vaccine. So the two things that if you have any allergies, you want to make sure, gelatin or neomycin. Is this important to have noted on every residence chart? Their allergies? Absolutely. And when we do these kind of vaccinations, especially when someone doesn't know their history, we need to make sure that this is a safe vaccine for them. So why do we vaccinate? Well, we do know that postherpetic neuralgia, or the pain that comes with shingles, is absolutely debilitating, or it can be. And we do know that even though this vaccine may not prevent shingles, it prevents in about 50 to 60% of the cases. It will prevent a case of shingles. But in those cases where somebody does get shingles, it does reduce the pain that's involved, or the postherpetic neuralgia. Safety has been established with the vaccine. We've been giving it now since 2006. We're in 2010. It seems like it's an effective vaccine, very few side effects. It's tolerated well, and it's effective. It significantly reduces herpes zoster and postherpetic neuralgia. And what we say is we believe it increases the quality of life, and that is everything that we're looking for in all that we do. When we talk about vaccination, people say, well, is it covered by Medicare? Do other insurances cover this as well? I would love to be able to say to you unequivocally yes and yes. What I've learned to answer to this one is check with your physician. This is a vaccine that usually a physician has to order. It requires refrigeration. When it is opened, it only lasts for 30 minutes. It is an expensive vaccine, and before I would say to anybody that for sure it's covered, I would tell you to make sure that you ask your physician or your insurance carrier if they cover the vaccine. And if not, ask why not. We know that the vaccine is very effective in preventing shingles, and also we know that about the pain as well. One of the things that I'm commonly asked, and whenever I have a classroom of people who are asking questions, they always want to know, how long does the vaccination last? Well, when you think about this, it was only developed and put on the market in 2006, developed long before 2006, but came on the market, FDA approved in 2006, so it's been available for 4 years. We know for sure that it's still efficient and effective at the 4-year mark. Every year they're evaluating, is it still effective? So I want you to know that right now, we know it's good for 4 years. Every year is something we have to look back and see if it will need any kind of a booster. So the need for revaccination has not been defined. We don't know. And as we continue to follow, it's sort of like hepatitis B vaccine, where we know it's still working all these years out. So it said, I have a question about, did you state that after 72 hours the MD will not prescribe an antiviral? That's usual. After 72 hours, it's usually not to be effective. I'm not going to say no physician will do it at the 80th hour or 82 hours, but I will say commonly after 72 hours, and this is the period that we really have to work within and make sure that we're doing what we should, letting the physician know. So yes, it's a 72-hour. Most of the literature will say it's not effective after 72 hours. Kind of the same thing that we see with outbreaks with the herpes simplex, with the genital type herpes, which is different from this one. We talked about Medicare D. And also, there's some benefit information that can be obtained for reimbursement support. These numbers are on the slides. These are not recommendations to call anyone, but they're numbers available to you if you need more information, and especially for financial assistance for someone. Let's get to the part that interests me the most, and I hope you the most as well, and that is nursing interventions. First of all, I want you to remind patients with shingles and postherpetic neuralgia to pace themselves. We've really learned that rest and adequate rest and good sleep is imperative for folks who are dealing with shingles or the pain that's a result of them. I can't stress this enough because as people become stressed, they get the shingles. And there is so much involved in the healing of this when they have the pain that we want to help people to rest. And we may need physician assistance with medication, but we also can do non-chemical interventions to make these people comfortable. They do suggest that we use light exercise. And one that has been especially attended to is Tai Chi. To improve the immune system is one of the reasons to do this. So a nursing intervention, and even maybe for prevention in the exercise and light exercise to reduce stress and to improve the immune system, is to recognize how important exercise programs are for our residents. I watch all the time activity coordinators in a facility offering exercise, sitter-size, doing these different programs for folks. I've even seen the drums and all sorts of things that are a healthy form of exercise, and yet we don't get the residents down to them. That's our job. Everybody's job is to get these people to exercise and to participate in these activities that even the joy of participating can improve our immune system. We have to remember that patients who are taking the tricyclic antidepressants and the opioids for the pain, that they need to stay well hydrated and to eat the high fiber foods. So how do we do this for somebody that develops a herpes zoster that is cognitively impaired? It's incumbent upon us to make sure that we're offering the fluids, that we're creatively doing this. We do a program on hydration that talks about using popsicles and Jell-O and making things and making sure that people are eating enough. But it's imperative that we look at the risk and benefit of things. We want to help with the pain, but not if we're going to have somebody so constipated and uncomfortable or even impact them, which is a sentinel event. We want to look at those issues as well. We want to educate patients about the open lesions and about the virus transmission. And this is where I said I would go back and talk a little bit about how we handle this disease and what we need to do for placement or care of these residents. As long as the vesicles have the fluid in them and that they are able, and you're able to see the fluid, they have not crusted over, this person is contagious to those who have not had chickenpox. Somebody who has shingles is not going to give shingles to another person, but they can give chickenpox to a person who has not had chickenpox. So I hope I make that very clear. A person who has shingles and has the vesicles and the fluid within the vesicles has the potential to affect or infect somebody who has never had chickenpox. The person will not get shingles, they'll get chickenpox. So let's talk about if we have a CNA who is assigned to care for a resident who has shingles, and the shingles are still in their eruptive and active stage of blistering. I would say to you they should not be assigned to the person if they've not had chickenpox. We also talk a great deal about a young pregnant person, nurse, CNA, anyone who is pregnant. Should they be working with people with shingles? And actually, The information that I've read is it is better not to do that, because we do know that the herpes zoster virus can affect a fetus. And in the late stages, they can even be born with a form of chickenpox. So I would say to you that the biggest issue is, have they ever had chickenpox? I do a lot of consulting and have in the past with organizations and working with employee health. And it's one of the things I don't always see asked on the health forms. We want to know about their hepatitis B, we want to know about their TB status, but we seldom ask if these people have had chickenpox or not. With the high incidence in our facilities and the age of our residents in protecting our employees, this is something that we should be looking at. Teaching and reinforcing good hand hygiene. Oh, geez, this is huge. It's huge for everything that we do. Hand hygiene is something that we cannot talk about enough. But in this case, for these residents, we sure don't want them transferring any of these fluids to someone else. The other thing is, with hand hygiene, I want to talk about for CNAs and infection rates, is the cutting of fingernails of residents who have the herpes zoster or shingles. If they scratch, and we know that these are itchy and can be very itchy, if they scratch, then what they can do is get an infection. In our facilities, we sure don't want anybody with staph, but more than that, look at where we are with MRSA and VRE today with infections. That's the methicillin-resistant Staphylococcus aureus and the vancomycin-resistant Enterococcus. I'm impressed I can say it that quickly, too. MRSA, VRE, by keeping the fingernails short on the resident, making sure that they scrub their fingernails, good hygiene of the resident, great hygiene on our part, all of this working together prevents the spread of infection. So it's very important. We thank you for joining us. Great to have you. See you again soon at mmlearn.org.